I'm here at the American Academy of Ophthalmology in New Orleans with Dr. David Chang, and we've just learned this year that Dr. Chang actually was able to experience his first manual small incision cataract surgery in his hands in Ethiopia. And I just thought it would be great to hear a little bit about your experience in doing manual small incision for the first time.
Yeah, very good, Stan. Well, it's certainly a humbling experience for any eye surgeon doing any new procedure for the first time. And, I'm certainly a big advocate of manual small incision cataract surgery, particularly in the developing world. But this was really my first chance to spend time getting to do it. We were in Mekelle, which is in the Tigray region of Ethiopia. And I was part of Jeff Tabin's team, where the team itself did 750 eyes in the space of 5 days. Now, there were only 4 microscopes, so a lot of people rotated among those microscopes. Jeff was, my instructor. What was really daunting was this population. Of course, all poor, many bilaterally blind, of course, many white and brown cataracts, but this is a region of the world where pseudoexfoliation is extremely common. So these were small pupils, they were wobbly lenses, and of course, as is often the case, there's trachoma with cloudy corneas, lots of pannus. And to me, the thing that, most of us wouldn't otherwise appreciate is just how important the lid drape is at keeping the oils out of the eye. So I thought it was just very exciting because you're operating in eyes with such pathology and recognizing how hard it would be to do phaco in the eyes with such lousy visibility. I mean, that's the thing with phaco. We're only as good as we can see. Mm-hmm. And as you well know, you're sometimes working with microscopes that aren't so good. You're working with a lousy tear film. You have patients that aren't necessarily as cooperative, and these really, really challenging cataracts. So to me, the really exciting thing was how well manual small incision works for those cases. My learning curve, I think on the first day I probably did 30, 35 or so. By the second day I did 50.
Wow.
And so it's a fast learning curve when you have a lot of volume. It definitely helped to, just like with any procedure, you don't even know what questions to ask or what to focus on until you've done some. And so when you actually struggle and say, well, this isn't so easy and so forth, and then I could go over to the next table and watch Jeff Tabin do it, or I could call him over. I had probably at least 2 or 3 occasions where I'm going, if I keep going, I'm going to drop the nucleus. So, why don't you come over and bail me out on this?
What was the most challenging part for you in the conversion?
Well, I think that it's actually getting the nucleus up and not feeling like you have to prolapse it or do some gymnastics, actually. I think the scleral tunnel, that was pretty straightforward. The capsulotomy is different. I was doing an envelope capsulotomy, the Ruit Tilganga technique. Certainly did some CCCs, certainly operating on, I've done phaco in these camp settings on these eyes, and so you certainly, with trypan blue, it helps a lot. But just figuring out in small pupil cases, how to get that nucleus out. And it's just like anything. Once you actually succeed and it works, you kind of know what your end point is. You kind of know how it's supposed to look. And even if it doesn't work perfectly the next time, you kind of know this isn't it, I've got to keep trying. And that was really the big learning curve, as you would expect. It's getting that nucleus prolapsed. And then once you get the pole out and so forth, then it's a lens loop technique.
Did you have to enlarge your incisions very often?
Didn't have to enlarge the incisions too often because I started off pretty darn big. Just sort of watching the surgeons at Erevan and their economy of movement and steps, I kind of went in thinking, I shouldn't even have to do anything to the pupil. And no, it kind of figuring out that sphincterotomies in the pupil are really important, getting that nucleus to come through. that that was a really important realization. And we've kind of with IFAS in the United States gone away from sphincterotomies and so forth now, but it really works well there. And then actually the cortical cleanup. I trained doing extra caps with the Simcoe cannula, with the syringe in my left hand. But kind of going back to that, you realize how spoiled we are with phaco, with a deep chamber. And of course, and then you do the white cataracts, and you sort of wash everything out. And then you do some maybe cataracts that aren't so dense, and you kind of go, "Wow, getting this cortex out is really
part of
time consuming."
Exactly.
Yeah. And so that reminded me of how hard that is. With the large incision extra caps, you kind of go way to one side and way to this side, whereas here you've got a tunneled incision, and subincisional is pretty tough.
It's pretty invigorating getting one of those black cataracts out and thinking, boy, I would have been sweating when I was phacoing that, and this is it just came out, and now I've got a clear visual axis.
Yeah. So I think that the things that I came away with it, like any surgical procedure, it really helps to have someone there. To ask or to bail you out or to go look at how they handle something. That one-to-one, is as important as internet video teaching is, textbooks, taking a course, and that is a challenge, isn't it, with learning cataract surgery? I just think, how could I learn golf just by watching videos and reading textbooks? You kind of need someone there to say, your feet are kind of pointed and the ball's going to the left because your feet are pointed that way, or you realize you're bending your knees or whatever. So that was important, and then really just driving home how for people that are inexperienced surgeons that need to operate on this kind of pathology in locations where you're really quite isolated. How reliable this is to just getting the nucleus out, and not dropping nuclei. In Ethiopia, in the entire country of 85 million people, there is one vitreoretinal surgeon. So, how would even American ophthalmologists function if they knew that if they drop the nucleus, they pretty much have a blind eye? There's no way out of that. So, I think that I'm as a believer, as much a believer as I ever was, that I think this is where people start, particularly in the developing world with bad cataracts in terms of doing cataract surgery. But even for me personally now, if given the choice, on those kind of cases, I'm just glad to have, again, the additional skills.
So you're ready to do it again?
Yeah, absolutely.
You set the bar high. 35 cases in your first M6 day. I'm pretty impressed.
I was just trying to keep up with Tabin.
Thanks a lot.
All right, thanks, Sam.